So with that, I'm going to introduce our exciting keynote. I'm really pleased to introduce Dr. Kevin Johnson. He is the David L. Cohen University Professor of Biomedical Informatics, Computer Science, Pediatrics, and Science Communication at the University of Pennsylvania. He's also Vice President of Applied Clinical Informatics at the University of Pennsylvania Health System. He received his MD from Johns Hopkins and his Master's in Medical Informatics from Stanford. And previously, he was the chair of the Department of Biomedical Informatics and Chief Informatics Officer at Vanderbilt University Medical Center. As a general pediatrician and clinical informatics researcher, Dr. Johnson was among the world's first researchers to propose and demonstrate the value of text messaging in behavior change. He also developed the first ever computer-based documentation system used at Hopkins and the first e-prescribing system used at Vanderbilt, both of which became platforms for numerous evaluations by him and his trainees. As director of the Penn Artificial Intelligence for Ambulatory Care Innovation, that's his lab, AI for AI, I love that name. He and his lab focus on various uses of AI to transform primary care. He has authored more than 200 publications and won numerous national awards. He was elected to the American College of Medical Informatics in 2004, the American Pediatric Society in 2010, the National Academy of Medicine in 2010, the International Association for Health Science Informatics in 2021, and the American Institute for Medical and Biological Engineering in 2022. Kevin is passionate about educating lay audiences about informatics. He's created 2 documentaries related to health information technology. His podcast, Informatics in the Round, features experts discussing informatics along with songwriters. I actually was just on an episode about AI replacing the workforce back in December. Highly recommend, it's a great episode. He also co-published a book series called Who Me, which is distributed by World Scientific Publishing, who also does our PSB publications. And it features scientists from marginalized groups encouraging young children to consider careers in STEM. It's a real pleasure to have Kevin here. I've been trying to get him to come to PSB for many years. He has been a mentor and a colleague and a friend of mine since we were both at Vanderbilt many years ago, and so I'm thrilled to finally have you here. Please join me up on stage. And as is customary at PSB, each of our keynotes receives a lei. So thank you so much, Kevin. Thank you for coming.
Thank you.
You're welcome.
Since I know we're among friends, it's a pleasure to get laid by Marilyn. So anyway. It was just sitting there. How can I not say that? Don't do that. Is that the first one that you've gotten? Am I your first lay? Sorry, okay, back. Okay. Well, hello everybody. It's a real thrill to have a chance to present some work that I'm absolutely in love with. And some work, quite frankly, that I knew I could only do at a place like the University of Pennsylvania. You see the title here, Improving the Practice of Ambulatory Care. And I'm going to do this in sort of 3 acts. Let me see if this works today. Yeah. So the first part will be about the promise and the reality of the project that we're going to talk about. It's a larger thing, larger initiative. The second will be creating this project, which we call the Observer Repository. And the third will be some early experiments, starting with a group we have called the Book Club. So this is not me, obviously, but as a physician, I went into medicine thinking that this was the kind of physician I wanted to be. I loved talking with patients. I loved having that relationship with families. It was why I chose pediatrics over internal medicine. And I really felt like I could make a big difference. And I felt like my generation was going to be one that really moved healthcare forward with some of the new technologies that were out. However, if you were to ask GPT, which of course we all do all the time, all sorts of things, to characterize today's health system using a little bit of retrieval augmented generation, this is the picture that we get back. And this is not inaccurate, as you'll see in a little bit more. So the data are pretty clear. Our health system continues to have the lowest life expectancy, especially among the developed nations where you'd really expect us to be leading. We spend more on healthcare than any other country. Admittedly, a lot of that is because we are also the technology ecosystem for the rest of the world. But nevertheless, we do spend an enormous amount and get very little back. I went into this really thinking that technology plus knowledgeable patients and physicians was really what was necessary. And Don Norman has a great quote, which is, "The power of the unaided mind is highly overrated." I think that's just great. "With external aids, memory, thought, and reasoning are all constrained. But human intelligence is highly flexible and adaptive, superb at inventing procedures and objects that overcome its own limits. The real powers come from devising external aids that enhance cognitive abilities. How have we increased memory, thought, and reasoning? By the invention of external aids. It is things that make us smart." Chuck Friedman, who's well known in our field, had a much simpler version of this, which he called the fundamental theorem of biomedical informatics, which simply stated is, humans aided by computers, and humans could be society, do better than humans. And you've heard Kurt Langlock's version of that earlier today. I was extremely excited, given those quotes and given my beliefs, when electronic health records took off. And I think you all may not appreciate this, but I always say it. In 2009, the legislation that was passed led to everything we do right now. Because from 1966 through 2009, most doctors' notes were handwritten with scratch. Most people didn't have problem lists. Only about 30% of the information at some point, 30% of the information in the electronic health record was actually incorrect. Many, many studies showing that patients had multiple blood types in the same electronic health record, for example. And so the use of the electronic health record really heralded the opportunity to do the work we do in precision medicine and now in AI. And so it was really exciting for those of us who were a part of that initiative, and I was one of those people, to see this curve happen. It was less exciting when data started coming out to talk about the collateral damage. So this is a seminal piece of work that was done looking at the overall usability of electronic health records. If you can't see where the EHR is on there, it's there. Not a great place to be. Most people who use electronic health records today would continue to give the present-day electronic health record an F in terms of its overall usability. And for those of you who've probably been using your patient portal, you're probably feeling about the same way in terms of some of the challenges of using even that technology. Furthermore, when we looked at the notes, we found that in our country, using the exact same electronic health record systems that the rest of the world uses, our notes are 3 to 5 times longer than those notes. So there's this enormous challenge with note bloat, which people believe is contributing to this new phenomenon of burnout. Certainly, the JAMA, New England Journal, and some of the more recent journals have continued to have editorials that come out and say things like this one: "Physicians, we hear you. Meaningful use," which was the work that was done in 2009, isn't meaningful. And the key points of all of this have to do with this idea that physicians and nurses, and sometimes patients, as you see here, are feeling in some ways very disengaged, powerless, and exhausted about the processes of having care delivered. So the world in which I started, which was really exciting to me, as a CIO at Vanderbilt, I slowly watched degrade into people saying things like, "Oh, I see we're implementing Epic. I hear that's the cream of the crap," right? And I was like, well, that's a good way to think about the $600 million investment we're making in our infrastructure. So needless to say, with this article, which is one of the ones I really resonated with me, our patients are becoming disillusioned about their caregivers and have dampened expectations for the care they receive. I won't read the rest of this, but with this article, coupled with some medical problems that I was experiencing and medical problems my family was experiencing, I started thinking a lot about what is going on here and how can we improve it. I think we all know what happened with United Healthcare and the subsequent collateral information that's come out about delay, deny, and defend, and it's just one of many, many, many problems. But you can feel the same tension that I think, describing at a national level when you think about what's happening in our healthcare system. A lot of what's happening has just continually added to what we call the cognitive burden side of this balancing equation, where more and more times we're dealing with error-prone interfaces, very complicated failure modes, slow response time of both systems and people, often they say because of technology, difficult data input, I can give you hundreds of examples of that, and then just usability issues. And what we want is what's on the right. We want context-aware information summaries, goal-aware clinical decision support, automated prior auth, which is dirty words, but if we're going to have it, it should be automated, trend detection and alerting, automated documentation, patient-specific data retrieval, and care support in all care settings. What we want is systems that make our job easier. Primary care is among the fields that are most in crisis. 80% of internal medicine residents including nearly 2/3 who specifically chose primary care, do not plan to pursue careers in primary care. Office visits to primary care clinicians are projected to increase pretty significantly into 2040. There is a need for over 50,000 new primary care clinicians by 2040. Just as a quick show of hands, how many people here have had difficulty scheduling an appointment with a primary care provider in the last year? Right, it's not a subtle problem. And approximately 48% of physicians report signs of burnout. That number is decreasing after the pandemic, but it's still very, very high. So in this whole setting, engineers and medicine teams have been thinking about what they predicted might happen in 2009. And the National Research Council actually did a report, which I highly recommend you all read. I'm sort of looking at you guys, I'm picturing Jason Moore, who was talking about digital twins. That work is seminal to the kinds of ideas that are in this particular report called Computational Technology for Effective Healthcare. And the key thing about this one busy picture here is that it tries to say that where clinicians and researchers would like to be is to have what Jonathan showed us, which is summaries and highlights of medical knowledge that's actionable, and virtual patients that help us to determine by modeling when a patient might be an outlier from their virtual self. What we wanted is the ability to operate in that level, but where the systems currently have us is in highly transactional systems with hundreds of papers per day that we'll never have a chance to read, some of which it turns out are error-prone or from predatory journals or any one of a number of other challenges. And what Dr. Stead and the team proposed in this monograph from the NRC was what he called radical change, which means essentially really thinking differently about the way work is done, the way people are engaged, and thinking about that cognitive support being heavily influencing what you and I build and try to deploy. So the question for me has been, how do we get there? Because the reality right now is that if I were to look at the technologies that are available today that clinicians should see but don't, this is that list. So these are technologies that are available in engineering that I would wager certainly 2 years ago, none of us ever experienced in our healthcare journey. But if you go to other fields, these technologies are either actively being researched or in commonplace use. In fact, most people who are engineers like us think about this when we go to the doctor. All we think about is how many things we could be fixing if they would just leave us to fix all of their problems, right? So there's many things here. Some of the ways that we could be using these tools include things like AI-based feature detection, being able to do summarization, which is coming, by the way, assessing cognition. In other words, assessing whether the conversation between the patient and the primary care provider is working. Are people engaged? Are they understanding it? Detecting unconscious biases. My favorite example of that is there are data to show that patients who have limited English proficiency actually receive a very different treatment guideline in most practices that are not facile in the other language. Quantifying activities, quantifying signs and symptoms, and a lot of other things. This room is probably loaded with ideas that we could use the technologies on the left, coupled with work that you all are doing, to come up with new things that healthcare could be doing on the right. But what keeps you from doing it is that you may wonder and wish that there was a searchable registry of primary care visits that you could watch, electronic health record data that you could review, audit log data that you could use to sort of figure out the processes of care that were happening, that you could then use for your research. But I would venture to say, if I asked you to raise your hands, unless you're actually in healthcare, your access to healthcare is terrible. We heard today earlier issues about Mimic-4 or Mimic. Mimic is the largest database being used by AI. It's primarily data derived from an ICU setting in Boston. So it's in no way representative. It's just accessible and really, really big. So the question I had was, could we actually create a resource that everybody in this room could use to get a view into the exam room and see what's going on with the computer, see what are the byproducts of computation, and actually get a sense of whether the visit worked or not, talking to the primary care provider and the patient. And so we decided to try to build that. And I was fortunate to receive a few awards. The first award was some pilot money at Penn, and then a few other awards from the NIH. You'll see that on my last slide. And to do that, these were the incremental steps that we started with. We had to create a vision that people understood. We had to find clinical sites willing to share the encounter data, and I'll go through the rest of these. So this is the vision, and just sort of to simplify it a little bit. Is there a pointer here? Yes. So the vision was that we would take outpatient and telemedical visits, and we would actually capture a video from multiple perspectives of what was happening in the exam room. Those data would then they would be a multimodal resource for researchers. It would include the audio from the visit, numerous versions of the video depending on issues that relate to privacy preservation, the actual transcript of what was discussed, the screen capture so that we could watch how EHRs were used in real time, linked to EHR data, audit log data, and then we would annotate the visit. We would ask the healthcare provider and the patient how the visit went. So we would take those data, we would put them into this integrated data set that would be completely de-identified and accessible to everybody. We call that the observer database. We would have abilities to do keyword-based retrieval. We would have multimodal synchronized data. We would then be able to deploy that and distribute that for all sorts of interesting projects. So that's the vision. A number of us agreed that we would go after that. It's obviously a very big, hairy, audacious goal. We spent a summer in the simulation center at the University of Pennsylvania, and we worked with clinicians to figure out a number of things, starting with just what would these videos look like, what would the EHR data look like if it was synchronized, how do we capture that, what are the user action log and audit log data would be relevant to all of you. And once we did that, I then had to go down the road and start convincing clinical sites to participate in this project. I have to credit Zach Kahani because I called two people, but Zach was probably the first who said, because everybody said, this is impossible. Patients are not going to consent to this. We wanted broad consent to see their entire physical encounter with a clinician. And people said, it's not going to happen. So Zach said, you know, Kevin, people give their bodies to science all the time. All you're asking for is one little slice. I think more people will consent if you do this right than other people think will happen. And so we went ahead and built protocols, we had a patient advisory group, a physician advisory group, and all of those groups helped to form what we were going to ask for in our consent. And once we had IRB approval, we then started working with one particular provider to look at a lot of different technology. This slide also shows all of the people from the Penn Simulation Center because we wanted to try out whether these different cameras were going to be a problem. Just to give you an example, we started out with a body cam, like the police wear, and Dr. Morgan was using the body cam and talking to a standardized patient who was presenting with depression. And she had her fill out the form that we often use to look for depression called a PHQ-9. She then took the paper version of the form and proceeded to block the camera while she was reviewing it. So we're like, note to self, we can't put this on people whose body habits make this impossible to see what's happening. So we then started working on using an egocentric camera. So now we have cameras that make you look like the Borg. There's a little hat, there's a camera right here, the doctor wears one, the patient wears one. We also tried the owl. We rejected the owl after a few visits. We now use a GoPro. And all of those data were tested. We proved that everything would work. And at that point, we were ready to go live. So we started at that point collecting data, and you'll see the results of that in a second. It's very important to note that for us to do a study like this, we needed to find out how we could de-identify these data. There are two different approaches we would like to take. I'm going to show you the approach we're currently using, which is essentially a batch mode de-identification pipeline. This work is all on GitHub. Anyone who wants to use it, we can show you how to do it. We used a lot of off-the-shelf open source tools, all of which actually need a little bit of help to be better. But nevertheless, this works. This slide may be a little bit hard to see. I'll blow it up. But essentially, there's a series of stages we take to get from the original data to something that is completely de-identified. Okay, there it is. So the first stage is pretty simple. We have an audio and we have a video. We actually extract the audio and then have that transcript generated from that using WhisperX. We then take the extracted transcript and we de-identify it. This is a JSON image of the data, so we're struggling with this. JSON image there. We use filter. Is anybody from a Toolboots group here? Okay, a filter is a tool that was developed by UCSF. Anybody here using it? Okay. So challenge number one, filter is really quite good. It's especially useful for the visit, the resulting documentation from the visit. It's never been tested listening to the actual encounter, which is where we are. So we are on the left side of that picture. Filter is useful, not ideal, but it works pretty well. We go from filter to basically a version of this that has some diarization, all named entities removed. This is actually very slow. I'm going to do this way. We then do audio de-identification, and the way we do that begins with a de-identified transcript that has all timestamps for every word embedded. We then go through the audio, and everywhere that we have a named entity that is lost, we replace that with either silence or a beep or whatever sound we'd like to replace it with. We then do video de-identification by starting with the original video, using YOLO V8 to identify all the poses that are available in the video, tracking each person because people go off camera and come back on camera, and we need to understand when that happens. There's a bunch of reasons for that. We then do interpolation if, for example, they're behind a door and we know they're about to reappear, so that we can keep that entire area blurred until they return, leaving us with three different possible ways that we can use the information we get. One is to do what's called a Gaussian blur, which is essentially blurring anything that is identifiable that we found in that process. We also, and this is just a spoiler alert, we're using option 2 for the data that you guys will see, the option 2 is we completely Gaussian blur everything, and then we add back either human mesh or key point versions of the people. And we'll see how but everything else is available and under broad consent can be used, but this will be the database that we hope to get to the entire world to use. And I'll talk about that in a second. Then we merge that with the de-identified audio, and we have a fully de-identified video. We have a lot of different ways to do obfuscation. I just mentioned a couple of them. And then the last step is, because these are such sensitive data, and because under IRB, patients do tell us how comfortable they are with various amounts of potential re-identification, we then go through a validation step, which at this point is actually manual, where we essentially watch the video to make sure that everything that could possibly be identifying is gone. We will be going through a third-party review. Brad Malin is actually the person, for some of you who know him. We'll be looking at this entire data set soon, but at the same time, this is what we end up with. We have a certain percent that fail this QC process. This is an example of the video. This is a fully obfuscated version.
Brian, he told me about your knee. We're going to talk about your blood pressure a little bit, okay?
So you can sort of see, there's a doctor using a computer. There's two people in the room.
The only thing you had was your A1C, which is the diabetes test, the tiniest bit high, not the diabetes. Brian.
Here we go. So we now have a fair number of these videos. We've had a chance to analyze where we are so far. The process that I just described to you takes a roughly 38 minutes for a 13-minute video, about 38 minutes to do the entire thing versus 100 minutes is what it would have taken if you had done it completely manually. And obviously this is a pipeline, which means we simply load it up into a very big computer and let it crank away at all of the videos, and there are outcomes on the other side, validatable data. The transcript accuracy is one of the biggest challenges we currently have. The current word error rate is 18% using Whisper, and that's something that we'll work on, but in general, it is not adding words, it's removing words, which means it's actually not so bad. We have video obfuscation performance, which is pretty good at this point. We have about a 2% error rate, and that we correct manually when we find it. The challenge is, I won't go through this slide, but I'll make sure that if you're interested, I can send it to you. It's all kind of online. But the numbers, there's a lot of work to be done to improve some of the tools that are in the pipeline, but this is our first attempt at it. We're going to put this into GitHub, and hopefully other communities will help us to improve this. I mentioned, and others have mentioned, that Mimic has issues. This will have issues as well. It will not be representative, but it'll be a different data set completely from what Mimic has available to it. We currently have, as you can see here, data from family medicine visits, internal medicine visits, a few neurology visits because we're doing some work looking at computer vision and aging, as well as data from our simulation center, which is surprisingly helpful for some of the work that you all might want to do or that I might want to do in computer vision. We do have satisfaction scores. We have a survey that we ask patients and healthcare providers to provide us. We actually tried to do what I would call the director's cut, which is we wanted to have both the patient and the healthcare provider watch the entire video and describe their insights. And I still think that would be an amazing opportunity, but right now, frankly, because of the burnout issues, both from patients and providers, even though they consented to do it, they typically delayed it, making it not as accurate as simply asking for a survey after the visit. So we have a data set, we have it de-identified, but now let's find out what's in it. So how many people here have been in a book club? A few? Okay, more people need to get in book clubs. They're really important. So we decided to create a book club. Now, if you've ever been in a book club, what you'll know is that book clubs aren't really about the book, right? What book clubs are is an opportunity to bring up a subject that has been published and to talk about both the subject in light of the book and anything else that it reminds you of that's of interest to your group, which is why so many people join book clubs. Unless you're Marilyn Ritchie, who reads 4 books a day, most people are barely getting through the book at the time the book club meets. So what we decided to do is to use a book club idea as a euphemism for a focus group. And we now have 2 purposely sampled focus groups who review the videos that we think are interesting, and we just go through them. So we have they see completely identifiable versions of this video, and we go through and say, what's there? We're now doing a thematic assessment of that conversation, but some of the key aspects, here's an example of a video from the OWL version of the version thing, and you can see a few of the people. Some of you may recognize some of them, there are many others. But some of the early observations were that the patient satisfaction scores are interestingly discordant, and not all the time, but some of the time, and that we often noticed when the patient would likely be less satisfied, which means there is something we see that is predicting less satisfaction, which then means we could create a real-time system to help alert that there is something that is happening that may make this visit less satisfying to patients. To take that to an extreme, one of the major epidemics in healthcare right now is anger. Patients who are encountering doctors who are burned out are often now hanging anger issues, and it can happen in up to 25% of providers' experiences. So what if we could predict that by just watching the video and listening to the audio and having a general sense that the sentiment is actually getting worse during the visit and maybe prevent some of the outbursts that have happened in clinics? We also noticed that PCP, primary care provider, attention during the visit is 94% on the computer. How many of you think that's about right based on your experience? Okay? There's reasons for why that is. A little bit of it has to do with the pressure to do this thing called the after-visit summary. And we are looking at some ways, and I'll talk about that in a second. But noticeably, more engaged interaction once this new technology came out, because we have videos from both before and after a technology that's just been out called ambient scribing. You'll see a little bit of data about that, which essentially is a large language model-based summarization of the visit. We are clearly seeing less use of the provider, less time with the providers actually at the screen, but there are some questions that come out from that, and we'll talk about those in a second. We're noticing incredibly high physician dominance. Patients are essentially having about 1 word or 1 sentence for every 10 that the physician or nurse practitioner states, which is not good. We notice very frequently unaddressed issues. Patient, I'll never forget this, and our group was very sad to see it, but a very busy but very interactive clinician who was spending so much time on the computer, he didn't notice that his patient, as she was walking out of the room, didn't use a walker. Now, we didn't know that she ever did. So as she was walking out, she said, well, doctor, I don't know if you noticed, but I'm walking without the walker. He was so busy typing up the after-visit summary, he just said, oh, that's great. So she's been working, she's so proud of herself, he gave her 0 feedback. I should also tell you that as a part of our physician advisory group early on, the one request that we had to honor was that nobody who was in the study as a physician wanted to have to review their visits. They did not want to see themselves on video, and I think in part because many people feel uncomfortable both with how they look on it, but also maybe even how the visit makes them act. We didn't unpack that, we just said yes. We're going to continue to think about ways we can get that kind of feedback to people, but it's very apparent, and the book clubs all notice it when it happens, that there's things that they would have wanted to know about if they were allowed to see it. We did have this occasional issue where a patient would come in with a complete surprise topic. And one of them was a whole visit, 45 minutes spent trying to address prior auth for a new medication, outside diagnoses that the doctor didn't believe the patient really had. Again, challenging for the patient and their provider, and we could watch it all on video unfold, and it was painful. And then other things, of course, how the EHR is being used during the visit. We have all of those data. We have not yet started analyzing it. So we have these data. We're getting really interesting results. The next question that I had to think about was, if we were to do process mapping, to what extent is the integrated delivery system at the University of Pennsylvania representative? Well, we know that we have a fairly good mix of incomes at the University of Pennsylvania. We know that our referral rate, meaning if you come to the primary care providers at the University of Pennsylvania and you have a rash, you will be referred to a dermatologist almost always, even if they have a general sense of what the diagnosis is. Many reasons for that. I don't like any of them, but that's the way it is. It doesn't require a membership. We know that preventive care is done, but maybe not done as much as in other settings. And we also know that although we have walk-in care, you essentially never see the same provider in walk-in care that you do for your regular visit. Probably the same experience most of you have. So the question is, how does that differ from all of these sites? So how does that differ from a federally qualified health center? Those of you may know those are sites that are typically funded through Medicare, Medicaid, other federal programs. They are typically much more focused on preventive care, tend to do fewer referrals, although they do them if they have to. They tend to take on more, and they tend to have a little bit better continuity for walk-in visits. You can see that there's also community primary care, concierge primary care. For those of you who don't know, that's like MDVIP, where you pay some number of thousands of dollars and you have your doctor who sees you for everything and charges a lot for that, but you get the care that you might actually want, and they typically do amazing amounts of preventive care. They are the closest thing to value-based care for people who are in the Kaiser system or the Geisinger system or some others that are now showing up. Those are systems that are per member per month, so they're membership driven, and they have a very different care model. So suddenly, when you think about that, this wasn't so representative, so we're now going through and collecting about 20 visits from each of these other sites so that our database will at least be comprehensive, possibly still biased in lots of ways, but at least a starting point. The last thing is we have questions, we have ideas from the book club. What do we do with it? So the book club came up with a couple of key things. Number one, we were aware that ambient scribing was happening, and the first question people said was, is it going to impact the quality and the utility of documentation? I'm going to bring that back up again. The second was, does ambient scribing negatively impact the quality of the primary care provider's cognitive work? In other words, if I'm used to typing the entire time I take a visit, to what extent does me not doing that impact my thinking? Those of you may know that when we write, we tend to remember. Sometimes when we type, we tend to remember. But if you're doing neither, and you've never been trained to do care without doing the other, how does that impact work? We've noticed a lot of patient concerns that were sort of unrequited. And is there a way that we could use a pre-visit chatbot to expose those concerns? We noticed that patient and primary care interactions with unaddressed issues and this issue of PCP dominance were areas where if we could use something like a real-time agenda management and feedback system, what I call an EHR adjacent technology, we could potentially transform that communication in ways that we would never be able to do if we were going to rely on an electronic health record vendor to do it. So, first of all, ambient scribing is here. How many of you know that your clinicians are using it? A few? Yeah, you'll see it used more and more. These are data that are part of an embargoed piece that is coming out in some random journal that I can't say, on some random date that I'm not supposed to say, January 31st, and it will talk a lot about the results at Penn with ambient scribing, and these results are similar to at least one other study that I know is about to come out, and they're all very positive. What's not positive, there's a couple things that aren't positive. One is the Net Promoter Score, if you've ever heard of that, which is a way to think about the extent to which one person's experience would influence their talking about the system to others. It's a quantifiable metric. The Net Promoter Score for most of us has been 0 for this technology. Nigam, do you know whether you guys did a net promoter. Have you done a net promoter score type analysis? Okay. If you haven't, you guys should. So it's 0, and we think that has something to do with different. Say that again. Okay. Maybe Chris. Anyway, so basically there's a population of doctors who don't like it. And that's mostly because they've created templates that work so well that this actually, in their view, makes their notes harder to understand. That gets at this last piece, which is 21% increase in the length of notes generated using ambient scribing, which is essentially large language model-based summarization. So it decreases provider screen time an enormous amount. It decreases pajama time, which is the work we spend at night finishing all the work that we couldn't do during the day, by a significant amount. And so the question to be asked is, what does it mean that these notes are longer? It could be good. It could contain more concepts. It could make precision medicine better. It could be bad. It could add a lot of noise. It could make precision medicine worse. And it definitely will take longer to read. So we need to do some studies to look at that. And luckily, we have the data now that we can do that study at our place. So the design is simply this. We take a look at visits where a scribe was used and visits where a scribe wasn't used. We use our existing pipeline to extract all the concepts, both from the audio, which gives us what I'll call recorded performance, and from the extracted concepts from the note, which is documented performance. And so the assessment would actually be, does the recorded performance and the documented performance get less aligned? It was probably already malaligned. I think we all know that, and we could talk about that. That's why we have to do it. Does it get worse or better with ambient scribing? And if it's better, it could be that the length has to do with the fact that there's simply more concepts that are being recorded now than there were before. You can see the numbers here. We have about 100 visits that have no scribe, but we have all of the data we need from our study, from the Observer repository to do the study, and we're now completing a study. We're going to try to get to about 40 patients where we have pre and post data, and then we'll do this analysis. Chatbots, the other question that we've come up. Very hot area. This is a PubMed review of the number of articles that have come out. You can see that in 2024, at the time that I did this, which was a couple of weeks ago, there were 89 articles alone in this year about the use of Previsit or other chatbots. I will not get into all of the details of this. Yiddy, are you here? Yes, that guy over there with a team of people who from my lab did a lovely study looking at retrieval augmented generation and focused primarily on about 25 patients who had gone through genetic counseling services and asked the question that's often shown as that radar diagram that we saw earlier. Based on a series of axes, do patients prefer AI-generated responses for genetic counseling over actual scripted responses from a genetic counselor? And you can see here that the red and the green, for those of you who are colorblind, if you will, the gray, is a very large percentage on each of the cases that was shown, out of each of the questions that was asked. The orange, which is essentially the human, was a smaller amount, and the blue, which is no preference, was also relatively small. These data suggest, as every study that's been done so far suggests, that in general patients are preferring AI-generated responses. The question then is there a risk to them? So, before I came in, last night I decided to play a little bit of a chatbot, make a little chat for you using GPT. Nowhere near as good as Jonathan's, but it's the best I could do.
Great. What brings you in today?
I'm here to see Dr. Jones. It's my annual physical exam.
Got it. How have you been feeling overall?
Well, in general, I've been a little bit depressed because Dr. Jones has been following me for more than a year with this itchy rash where we thought that there might be even insects coming out of my skin, period. He never did any real physical exam, but I went to another doctor who said I had pinworms. I wanted to talk about that with him.
I'm sorry to hear that. Have you noticed any changes or new symptoms with the rash since you last saw Dr. Jones?
No, in fact, the new doctor told me to start taking ivermectin for the pinworms, but I just wanted to make sure Dr. Jones was okay with that, since I also take Lasix and rosuvastatin for other illnesses.
It's good you're being thorough. Have you had any side effects from the ivermectin so far?
I haven't started it.
All right. It's important to discuss this with Dr. Jones, especially considering your other medications. Do you have any other concerns or questions for today's visit?
No, I'm just kind of depressed, but I'm hoping he and I can talk about that.
Absolutely. It's important to address how you're feeling emotionally, too. Dr. Jones can definitely help with that as well.
Yeah, I guess it's making me pretty sleepy all the time, and I guess we should talk about the sleepiness, maybe the fact that I'm not eating and I've lost some weight because I've just been so sad lately.
I'm sorry you're feeling that way. It's important to share all of this with Dr. Jones so you can get the support you need. Is there anything else you want to mention?
No, that's it.
All right. Thank you for sharing all of that. It's really helpful for Dr. Jones to know. Let's make sure you get the care you need today.
Okay, I'm done.
All right. Thanks for sharing that information. Dr. Jones will be able to help you from here. Take care.
Would you summarize, please?
Certainly. You came in for your annual physical exam with Dr. Jones. You've been feeling depressed and have an itchy rash that another doctor diagnosed as pinworms, prescribing ivermectin. You're also taking Lasix and rosuvastatin and wanted to ensure it's safe to start ivermectin. You've been feeling sleepy, not eating well, and have lost some weight due to sadness.
Thank you.
Okay, so that's zero shot, two mornings ago, GPT 4.0. Not bad. It does bring up some questions.
Great. What brings you in today?
Stop it. Safety.
I'm here to see Dr. Jones.
Nobody wants to hear this twice. So safety issues. I did everything I could to see whether it was going to begin to ask me more questions about depression, because depression is one of the triggering questions where you might expect the chatbot to say, maybe you should see someone before your appointment, depending on whether or not I'm suicidal. I never quite decided to say I was suicidal. I didn't know what it was going to do, so I decided to just see how far it would go by asking me questions, and it didn't. Quality. It may have asked all the right questions, it may not have asked all the right questions. That's something that we'd have to figure out how to do with rigorous science. Usefulness, no way to know. We have to study that. And then the last thing, which I'm sure is going to start it off again, is liability. There is some risk to this that if the patient were to have a bad outcome from it, this system would in fact have a liability issue. I can tell you the good news here is that we are not the first ones to think about this. There are numerous industries thinking about chatbots, not so much in the pre-visit space, and we are looking at what it would look like to partner with some of them because they have some very robust tools that can help us with quality assurance. But you can see GPT-4 has gotten to the point where with enough prompt engineering, and this was a fairly easy prompt, it worked fairly well. So there's some work to be done to improve this and to understand it and to study it. The other issue, actually let me go back to this. So one of the things that we've been thinking about in terms of how to study this is very sensitive information. The typical studies are involving, we'd love to get these in front of patients, but there's the risk, as you've seen if you saw the recent story from Google about the child that received the app, there's lots of these examples, that the concern is that if these misbehave and we don't catch it, there's a possibility for damage downstream that we would have liked to have known about before we actually brought it in front of humans. But at the same time, anything else that we do is going to be a highly artificial study. So what we are now working through, and hopefully maybe if I come back next year we can talk about it because we'll have the study done, is using standardized patients, because standardized patients have cases that they have learned as actors to portray. So we would have standardized patients actually be the patient and the reviewer of the summary, because the question would be, does the summary align with the case description they were trained on? And so we're working through right now with colleagues Matt Weinger and others at Vanderbilt ways that we can create this brand new method using standardized patients that I think a lot of other places in the country would also use to evaluate these. This other one that we're looking at, which is this issue of exposing unaddressed agenda items, is absolutely fascinating and is really going to be, I think, a terrific thesis for one of my people in our lab, a guy named Samir Badi. But it's how do we create an agenda item that is understandable to both the patient and the healthcare provider? How do we decide when that agenda item has been addressed? And how do we prove that there are certain areas where doctors actually would need this agenda item. The case that I just did by chatbot needed an agenda item because we watched that case and saw some of the challenges. We've also been looking at ways to characterize clinical interactions. I'll just, for time, it's 12:05 and I have till 12:15, so let me not do this. If you have any questions, I'll explain it. But we've been doing some work using basically spectral analysis of the audio to try to assess sentiment within the audio coupled with the video, with the transcript. And we're making some headway on that work. So I expect to have some work to share. Much of the early work is in GitHub from a student of ours named Andrew Zelensky. And again, I can share those papers if you're interested in this area. But we're very excited about that. We think we're going to make some good headway. So the next steps are you guys. Because what I'd like to do is to recognize that to make any real practical change to transform healthcare, we need to be thinking about both the technology, the processes, and the people. It's not going to just be about the methods that we use in AI. It's also going to be about training and fatigue mitigation and the motivation to use these technologies. And as always in informatics, the pyramid is inverted. So the technology is the easy part and the people are the hardest part. But we need to get the clinical trials of this work to address issues around equity and fairness, to get issues around the learning curve, et cetera. I'm always reminded that there is a group of people like this, many of whom have barely learned how to use anything on their phone other than 1 or 2 apps, and we're now asking them to do an enormous amount more. When I first started with electronic health records, most nurses had never used a mouse. And so we had to create entire training programs about mice and trackpads. Guaranteed, we're going to have to do the exact same thing for AI in clinical environments. There is a major concern about expendable jobs, and as Marilyn mentioned, we just had a great podcast about this particular issue, but we are going to have to address this as a community if anything that we're building is going to be usable, because we're going to need to get people willing to adopt it. And I won't read through all of this. The thing that others may find of interest is, I talked a little bit earlier about the fact that precision medicine was born on the back of the electronic health record and of the documentation that was a byproduct of that health record that often caused pajama time. So if you take that model that I've already shown as a way to de-identify the data, there's a study that someone in here needs to do, which is to take the concepts from a visit and find the recorded ICD-10 constructs and compare those to the documented fee codes, if you will, that could be generated from that note, and to see whether ambient scribing actually decreases or improves the recorded versus documented fee code opportunities. In other words, to what extent are we actually going to make precision medicine likely worse as we go through the process of improving cognitive support in the exam room? This would be a great study. I'm happy to talk with people about it. I have a sense of how to do it. I've got enough to do. So if there's people who would like to do this, I would be willing to talk to you. And that brings me to the last point, which is the reason that we've been building this is for you and for other people in the country. So we're now working to create a consortium to get other sites to contribute the data, think Mimic. We're also going to start a set of observer challenges so that we can start to improve the applications that we need to create this de-identified data set. And hopefully some of you will be able to help me. Yes, these and all of the other pictures you saw were generated by Sora and other tools. So in conclusion, the Observer Repository is being built and will soon be released for general use. There are numerous opportunities to inform every discipline interested in healthcare improvement to get you in the room and see what's actually happening, all of which will be searchable with metadata. There are opportunities to improve the DID stuff, and we're designing interventions right now that we'll be testing in primary care. And I'm starting to feel a little bit better about healthcare again. I want to thank my lab. There's a lot of people here. There are also alumni that I didn't put on this slide, and these are the acknowledgments for my slides, including all the videos that you saw. Thank you, and I'd love to answer questions. So quiet. Okay.
That was great.
Thanks, Larry.
I want to ask you about the ambient scribing thing.
Yeah.
You touched on so many things that my head is full, but that one I have a personal story. I know I'm not representative or even formal, but I had my first experience with ambient scribing the last encounter I had with primary care doc 3 months ago or something like that.
Yeah.
And I was just really surprised at the notes. So one of the reasons I'm not normal is I always read my after-visit notes anytime I see anything. So I know that that's not normal. And the difference between the scribe note and the ones that I had seen, my entire history before, was it did a much better job of capturing what I said. And there was absolutely no sort of clinical judgment or intuition in the note. It could have been, thank you, could have been just a transcript of my part of the conversation without any interpretation or analysis. And I found myself disappointed by that because I was hoping to go to that note to find some analysis. So I think when you say, we don't know whether or not it's going to improve things or make things worse, is the longer note better? I think it's probably both. So it's going to capture some of those things that got dropped on the floor that, in that 10 minutes just didn't make it into the clinician's head about what might be important. So it's nice to have that.
Right.
But on the other hand, it also seems to me to have utterly lost the sort of the clinical expertise part of that note and just reflects what I walked in with my problems and what I had to say. So how are we going to get the best of both of those things? What are we going to do to both capture the things that otherwise would have gotten left behind, but still make it not just a clinical judgment-free rendition?
That is really a terrific point. And you're making 2 points here. I think the first point that you're making, which is so important, is patients' review of these notes, now that patients are a part of the discussion, has not been studied. So far what we've been trying to say is, will this note pass from the standpoint of helping to mitigate, increase cognitive support, mitigate burnout? So that's a really important observation that I think we have to all take back, and I certainly will. And then the second is, there are opportunities for the physician to improve the note. So the typical workflow, if you look at the 1, 2, 3, 4th line, not counting the titles, percentage of characters and notes composed by HCP, we have the ability in our EHR to see what the original ambient scribing note was and what the clinician added to it or took away from it. And what you're getting at is, was that something that was there and removed? Was that something that was not there and should have been added? Does this particular clinician typically include that? In other words, is their documented performance worse now because they're missing some concepts that would have been present before? And that's exactly the set of questions to be asking. So we don't have answers, but I think you're pointing at why it is that we don't take zero-shot stuff and stick it in front of patients.
All right, so I know there's other people. I want to ask one other completely different question, which is about consent. So I'm curious about your consenting process for this whole thing. Do you consent the physicians? Because there's clearly reputational risk, if not others, for them. And do you consent the payers? So insurance companies, I think, are going to be very nervous about what you find in that exam room. And, ICD-10 coding and all that sort of stuff is really largely around money rather than around care. Yeah. And so you're messing with a lot of that. I'm kind of curious how broadly you consented what you might consider participants in this study.
Important point. So first of all, it is broad consent, so we can use it in the future. It is both providers and patients, and we actually pay. We give gift cards for each encounter that we record. So they're highly motivated as much as we can to do something that they said they were willing to do from the very beginning. We also needed their help to make this seamless and fast. Clinics have to work perfectly, which means we had to learn over the first few months how to get in and get out and get all these data from everybody, including these surveys. And so for all of those reasons, we consent and we provide an incentive. Insurers? There is absolutely no world in which I'm going to be talking to an insurer about this study. So we will definitely be asking for forgiveness if and when I find out a reason. I can tell you that our ethics group has not felt that there was any concern that the insurance companies needed to know about it or payers needed to know. I would also say most of our academic centers are actually self-insured, right? So to a certain extent, any employees who come in, I have gotten their permission because Kevin Mahoney, who's the CEO, paid for the first year of the study before I got my Pioneer Award. So, yeah, I got one. That's a good point. Yes?
Thank you for a wonderful talk. I have also a question about the ambient transcription. Just wondering if you could comment on this. A couple of months ago, there was this article in the news, NABLA, one of the providers of this technology for ambient transcription was in the news, unfortunately, where a lot of the technology is based on this Whisper AI platform, and that's been found to have up to 50% of the audio that gets transcribed contains hallucinations.
Yeah.
And so when ABLA was asked about, if they know what the rate of hallucinations is in their transcriptions, they couldn't answer because they didn't keep the audio, right? So they deleted the audio, all of the audio for the 7 million transcriptions that they have done had to be deleted. That was their privacy strategy. And so they have no idea how much inaccuracy or hallucinations there have been in those transcriptions. That's the story that was in the news.
Okay. Yeah.
So I'm just wondering if you have any comments on that.
Yeah, so all three, there's many of these vendors.
Yeah.
Every one of the vendors, for the reasons you might imagine related to privacy and security, and the fact that patient consent for this is a little bit of an afterthought. I mean, if you've ever been through it, typically the provider says, is it okay if I record the visit? And they don't really know, most people don't really know what's going to happen downstream, except a magical note appears at the end. The actual audio is actually in the EHR. So unless NABLA is doing something different than every other one of these, the provider has a copy of what they said and the actual output that they can use to edit. Most people don't access it, but they have access to it. You wouldn't want NABLA necessarily, or OpenAI, or any, to train on these data, although frankly Nuance has been training on dictations for decades, and that's how they got so good so quickly. Nuance was purchased by Microsoft working with OpenAI, and then you end up with this tool. So it is a concern if NABLA says that we don't have any way that we're doing quality improvement because we are giving away everything. I'd be a little surprised if that's really, I haven't seen that report, but I'm quite aware of the fact that the other companies are not doing that the providers have access. That's how we do this study, is we actually go to people who have any scribing, and we grab their transcribed raw audio, which is in the EHR.
Okay. So, and in that Observe platform that you mentioned, is the actual audio available and the video?
Mm-hmm.
It is. Okay.
All of it.
That's wonderful.
So have at it.
Yeah.
Next question?
We can't.
Oh,
It's lunchtime.
I'll be around for lunch if you want to find me.
Talk to Kevin.